Dear colleagues, dear participants, it seems that now we are going to have a private practice day as a second day. From the first day we had more scientifically oriented and from the professors from university. When you're coming from a private practice as I am, you have a bit different approach to the patients. You know, when they fail in their research, it's also some kind of success. They know something, they gain some information, they know why it fails. When it's fail in your practice, then you lose your money, your patient, your reputation, you have a headache. And now I would like to talk and tell you some guidances regarding restorative part of prosthodontics. I'm coming from Belgrade and I work in a quite modern environment, and this is our practice. It's in the middle of a center of the Belgrade, in a very nice area, but the practice are not the premises. This is my team. Today I learned from Dr. Bayer very nice word, implantology. It is really teamwork, and implantology could not be led and employed only by the one man. And this is my team, and we are considered as one of successful practices in Belgrade. But once you start being successful, trying to do your best, then you attract more and more prima donnas in your office. And when you get more prima donnas in your office, then your stress level is going higher. So during this lecture, you're going to hear some information how to release the stress and how to plan your final outcome for the better clinical result. We passed along the way from the 1982 till 2013 now, since Professor Bernemark published his first article regarding osseointegration. And with that, the prosthetic standards and aesthetic standards shifts from these type restorations to something very, very precise, very high demanding, and very skill demanding to achieve such nice restorations. Although many factors were quoted in a previous lecture, but there are really some aesthetic factors in correlation that we should think from the moment the patient show in our office requesting some restoration on implant, and most probably asking in the same visit how much it's going to cost. So he needs just that information. Would it be painful? How much it costs and how long it would last? And you need to consider about many things that I put on the slide. I want them read them one by one. On the other hand, there are also, when you put the implant, the factors influencing tissue remodeling about the implants. They are, I made a group like this. Maybe you can invent something more, but there are anatomical factors. There are also surgical, very important factors. Factors regarding the implant. Patient-related, and of course, what is also my concern is our prosthetic factors. They are influencing on remodeling of the soft and the hard tissue around the implants and giving us predictable long-term result. Speaking about these two targets that are going to be submitted on the implant restorations, you also need to take care about the midline and take care about gingival level. It's very important to maintain this gingival level where you are replacing single implant and put in single implant restoration. I heard about 19 minutes for fast and fixed restorations with very highly skilled surgeon as a Dr. Bayer is. But in Belgrade, there are not such surgeons as a Dr. Bayer or similar. Some young dentists claim that they can make restoration put the implant for 10 minutes, but 10 minutes implant sometimes in 10 months of your headache and restoration procedure. So what you need to know as a restorative dentist or prosthodontist, and also as a surgeon, is correct mesiodistal position of the implant. There's some kind of comfort zone and danger zone. At least you need 1.5 millimeter from each side of the bone to have a stable result. 2 are recommended. Also, the position of the implants, we heard a lot about that in the yesterday lectures, but the proper buccolingual position also should be a bit palatal. You know that from previous lectures as well, but keep in mind that you need this comfort zone for a proper blood supply and proper nutrition or hard and soft tissues. These are our models for today's lecture. And we have one also male model, but he didn't want to take photographies. And I will start with the first case with Joanna. She had a perio problem with some tooth fracture and single request surgery. This is her smile line, and this is the slide from the previous part of the lecture. We needed to extract it due to perio problem these two teeth and to replace them with implant restorations. There were some crowns left and right of adjacent teeth, but we, for this moment, decided to remove them as well. These are the removed crowns, and this is a treatment planning sequence. We decided to extract 21 and 12 implant replacement to reevaluate the healing process, to make immediate loading and the final temporary restorations immediately, aesthetically driven soft tissue manipulation, then to reevaluate and then finally restore with individual abutments. This is the implant side, this is the extraction side. These are the spaces that we have left after the extraction. And what you need to know about this correct mesiodistal position in a comfort zone, again, is that you should definitely measure. And it was previous doctrine when you had to fill the socket with the implant. It was some 15 years ago, but now we have something new. Now we have some new findings and results, and definitely narrow diameter implants are much more convenient with that. So if you have from tooth to tooth, for example, from tip of a papilla and tip of a papilla 9 millimeters, and you can easily go with 2 millimeters around with a 5 millimeter implant. But then you are going to have a problem with the future recession. You need also to measure the bucco-palatal diameter, and when you have something like this, the key for success is that buccolingual dictates the diameter and mesiodistal only if it's narrower of these two. Socket preservation, we heard a lot about the mind the gap sentence, and what is the take-home message is that implants do not prevent the bone resorption. There is almost 50% of horizontal and vertical bone, and it occurs in the first 9 months, but majority of the volume is going to resorb in the first month. So proper socket preservation is also highly recommended. Then again, immediate implantation, 50% recession occurs first month, and gingival recession could not be avoided even if you put the implant. So it could be from 0.6 millimeter to 1.6 millimeter in general. So from the implant side, we need to maintain this tissue volume, hard and the soft tissue volume, and we decided to implant the implants, and this is a 2 millimeter subcrestal position as recommended yesterday. This is the implant site, and we need to fill this bony envelope with augmentation material, but before you do that, take the impression for your temporary restoration. The best way to do it wisely and let's say securely is to cover these implant transfer with sterile glove material, latex, and then take an impression to avoid the entrance of the impression material inside of the healing site. After that, we do the connective tissue graft, put it inside, and finish the procedure like this. 3 days after we received the temporary crowns from the lab, and we opened the implants, we decided to go with the splinted implants since we didn't have a control to a patient since she lived abroad. And what you need to know from this slide, the professional phase of treatment can be the most challenging aspect in all the implant dentistry. Now you're trying to shape your future result and give it the proper volume of the soft tissue and the aesthetic outcome. 60 days down the road, the healing site looked much, much better, and we decided to start the manipulation with the soft tissue. So what are now the clinician expectations? We have really a lot of explanation from such restoration. It is a placeholder. You need to evaluate the function, you need to evaluate occlusion, you need to evaluate phonetics, facial analysis, whatever, but the patient has only one expectancy from you, immediate and aesthetic provisional restoration. Emergence profile entered into our daily routine just recently, but it was published, the works were published in the 90s, and suggesting us that if we want to preserve the hard and the soft tissue in a best manner, we need to follow the contour of the natural tooth. The tooth is not cylindrical, the abutments should not be cylindrical, the abutments should have the concave form of the natural tooth root form. And the most tricky part here is how to sculpt your tissue. You can easily manipulate with the composite, you can easily manipulate with the resin materials, you can add some to push papilla approximately, and you have to make it concave to give enough soft tissue volume to have a long and predictable stability throughout the time. So don't be afraid to push papilla. The papilla and the soft tissue need some pressure and need some very precise contact point in order to achieve the proper length and proper volume. This is the way you manipulate with it. This is the, again, next phase when you restore it with in a proper manner and wait for another part of the healing period. 6 months down the road, we ended up with this result. We maintained the soft tissue and the hard tissue volume. We put some implant transfers, and we maintained also the emergence profile, what we wanted to achieve from the first place. How you can take precise impression, and for a single implant restoration, there are different materials. You can use a pattern resin, as seen before. You can use also the flowable composite, but there is a really strong need from your side to provide technician information what is in the real design of this soft tissue configuration. I suggest always monophase impressions for in-implant dentistry, and they are most precise. After you take impression, it's up to you to decide what you are going to do and what type of the abutment we are going to use. There are different studies, there are different researches, but what came from the experience and what the group from Zurich published is the recommendation for single tooth implant reconstructions. They quoted something else. Abutment for material single unit case, it should be determined what type it would be regarding the high or low lip line, regarding the biotype of gingiva, whether it is a thick or it's a thin biotype. The color of the neighboring tooth also is very, very important regarding the final aesthetic outcome. In aesthetic demanding cases, customized ceramics abutment are also indicated. Regarding the thin peri-implant soft tissue, zirconia and all ceramic crowns are highly recommended. Now we have BioHPP. It would be also the next step forward in meeting patients' experience and aesthetic results as well. Thick mucosa can deal with titanium, and titanium can be used as abutment material with porcelain fused to metal. But if you have submerged implants and difficulty in removing excess of cement, screw-retained reconstructions may be preferred, and if the screw access holes is positioned palatal, then you go with straight with screw-retained one-piece restoration. If the access hole is a lingual and if access hole is a labial, then you make individual abutment and subsequent all ceramic crown. How are we going to retain those crowns? The crowns you can retain in implantology with permanents and with temporary cements. They are all famous materials, and all materials from your office are almost suitable for retaining the implant-supported crown. But what is now in focus in modern implantology is the screw retention, and now we are shifting more and more toward screw retention in implant dentistry. Most frequently used cements are zinc phosphate, and their loss of retention in temporary cementation is just a bit higher than with the permanent restoration. But we need to take into consideration a couple of very important issues. This is a type of surface, conicity of abutment, whether it is a straight or it is big conus, while from the lab came out, angulation, type of cement, interocclusal space as well. So it's highly recommended that in long span bridges you should retain them with the screws, but short bridges and single implant restorations could be cemented with success. There are also pro and contras for both types. In a cement you have sometimes better aesthetic, we have better occlusion control, less ceramic fracture, no screw loosening, and passive fit, which is very important in implant dentistry. But in screw retaining, minimal durability. If you have very minimal intraocclusal space, it's better to screw the crown on the implant, and you have no cement excess at all. There are lots of papers. I quoted the one. It seems to me very interesting, the positive relationship because peri-implantitis is excess of cement. And Thomas and his group gave a conclusion that in a majority of peri-implant cases, the excess of the cement was a cause in 81%, but once they open and treat it and remove it, the 74% just healed and become very healthy peri-implant site. Some of the solution could be also the vent holes for cement excess and evacuation. You can do it in lithium disilicate, you can do it in porcelain fused to metal, and that could be also one of the solutions. But going back to our case, we received the individual abutments and the crown cores. We put them in a mouth. This short ischemia, the slight ischemia you see, is a response of a soft tissue on an empty space for approximate time of 10 or 15 minutes. Very soon it goes away, but if you want to avoid that, you can put the duplicate on a plastic or whatever inside. Even a hard silicone mold could be used for that to support the tissue while you're manipulating with a prefabricated or individual abutments. We put the abutments in the implants, and what you need to know also that they are biological elements. You need to decontaminate them. You put them in ultrasonic bath in alcohol for some 5 minutes and remove all the debris from them. We get very nice soft tissue profiles around, and we thought that this is a path to success. This is a finished work. We were really quite satisfied that the crowns are in aesthetic that our patient demanded, to be very white and to be very not so individualized, but what considered me the most was this, and the final outcome was really, really nice. Is that integration? I think yes. Is this a real goal of implantology? I think it is. So now with the control X-ray, with the surrounding bone and this hard tissue morphology, I think we are going to have a very good result. Second case is my friend. He's my age, and also with the friends, you always have some problems. With the friends and the relatives, it always happens something you don't want, that you don't expect. But this perfectly filled and endodontically treated molar ended up with a fracture. You know, this when you have a friend and you ask him to come for a permanent restoration, okay, next week. This is after restoration and post-endodontic time, for example, a year, and it ended like this. We removed the tooth. We had to remove also the septal part. We decided to go straight forward with a braided implant length of 12 millimeters. and we implanted that in a socket. But we ended up very deep with it. We had a very good primer stability, but it was very, very deep. And what was very convenient for us is to use the healing abutment from Braden, two-piece healing abutment. It is a straight, and it gave us support for a bone augmentation material and for the membrane. So we closed that for some 60 days. This is the X-ray of the immediate implant site. After 60 days, he shows in our office, and we decided to deploy another very nice product from Braden, which I really adore. It's a Skype temp with this particular size L, and we put it inside and wait for another period, or some kind of 1 month. After a couple of months, we removed the material, we removed the temporary abutment, and we gained very nice soft tissue architecture around the implant side. What was the real trick in this case is that in this region, he missed the 2 teeth, but we had a very strong mesial angulation from the distal one. And this was a space, for example, 1.3 sizes of the molar. And we decided to transfer the information to technician about the shape of the contour. And this is how it looks. But now you have a very good new product. We didn't have that at that time. This is Sky Aesthetic Impression Abutment. So it will totally remove the need of individualizing this space. We used the Sky Unifit abutment, and we decided to do the screw retain restoration. At that moment, we had the Unifit abutment. Now you have also Sky Elegance abutment, so you can produce a very nice, also a platform switch and very nice aesthetic contour immediately from it. So this is our final outcome. And this is a screw retained crown on a model. This is a crown in the mouth installed with the hole is filled with the composite. And of course, before you cement it, use some chlorhexidine gel to decontaminate the site. It's very, very useful for that. Also, some scientific articles are published on that matter. This is the contact point. This is a hygiene instruction to patient, and this is the final outcome. I'm really curious how it's going to look after 2 or 3 years and what is going to happen with this hard tissue here. But I think it would be anyway success if he maintained hygiene in a very good manner. Next case is Milica. She has a congenitally missing lateral incisor. She is a nice young lady, and she went to our clinic to get the new smile for her prom night. And she asked for some veneers or some crowns and how we're going to deal with that. But what we try to do is to convince her that maybe it's wiser, after some analysis, to undertake some orthodontic procedure, to move the canines on a distal position and to release the space, to put some implants or some adhesive reconstruction on the lateral incisor site. She was smart enough to accept that, and in that age, she was at that time 17. The young kids are not so smart, and they don't like to wear fixed appliances, but she agreed. So what could be solution? And the solution is always to establish the overall balance in a facial expression, definitely, and the 2 treatments, closed or to open. So we made an orthodontic appliance and the orthodontic therapy, and after some 11 months, we gain space for putting the Nero implants there. Now we have also from Braden Nero implants, and they are released very recently, but it's very useful. Nero 2-piece implants are giving you very good maneuver space for future restoration. Very aesthetic one. We did the flapless surgery, We put the Nero implant in the lateral side, and we put the immediate temporal crown in immediate loading procedure. So after analyzing her smile, although wearing the orthodontic appliance, we decided that we need some kind of crown lengthening, that after orthodontic treatment everything went down and on position. We have some also hypertrophic, the pink tissue. We decided to do some kind of crown lengthening to establish the harmony with the canines. And the procedure was very easy because of the enough volume of biological width. And this is the final result, and at that moment we decided to make the permanent crowns. This is a very nice tissue around the implants, and we removed orthodontic appliance. Of course, we gave a retainer to her, and this is the impression procedure. On the x-rays, you saw that the implants were quite close to the teeth, but due to the position of the impression copings, you see that the implants were oriented toward palatal, so they were not harming in any way the adjacent teeth. Always check this with the x-ray before taking impression. It's very important to see that everything is in a place. When you have submerged implants, you doesn't have always the feel that you are on the right position. So take an x-ray, impression procedure, and these are titanium abutments. And I think that our definite work is quite successful. This is the Milica afterwards, and from the very charming young girl, she became, after 2 years, very good-looking young lady, and she enjoys her smiles a lot. And these cases always push me further and further, because speaking about fast and fix, speaking about the huge restoration, sometimes this is defeat for the dentistry, because we are making corrections of lost teeth. And this one is, I think, paramount of implantology when using in minimal invasive treatments. And this is how it ends. This is how we started. Our last case for today is Verica. He is 58. He is heavy smoker. And at the end, she is from Australia, which is on the other part of the world from Serbia. Every year she is for 3 months in Serbia because she has Serbian origin. She showed in our clinic with such situation. She demanded the fixed restorations, and looking at X-ray, you have severe bone resorptions in upper jaw with the very low sinus floors, with the root, with the apical process here, infections. Lower jaw seemed quite better and more predictable. While examining it in a cone beam CT, we realized that we really don't have anything that we can use with, and we need to deploy a very big volume of bone augmentation technique. Coming lateral from the second incisor, we almost had no bone at all. Very thin on the side. In a lower jaw, the situation seemed better, but doing some cone beam analysis, we realized that in the frontal region where we expected to put the some amount of implants, we are very thin with the bone. And
Igor, we just have 5 minutes, please. Yeah.
Okay. And we decided to go with the implants, sinus lift here, and the implants lower wide, because in this region we expected that maybe we need to do the split ridge technique, and we are going to lose some of them. We decided as well to go with the immediate implant rest loading in frontal teeth to make upper 4 supporting implants, and with the laterals with the canines hanging left and right. Again, please check the impression technique, because in this case we missed some kind of dimension here, so we needed to correct it. Impression taking. And we finished after 2 months and a half the lower jaw. This is the situation that we need to fill the lower jaw with a permanent restoration, and we left her in Australia for the next year treatment for about, these are the temporary crowns. Next year she showed in our office, so we started the procedure to finishing the upper jaw. This is the first impression, and the second impression we did the same procedure that Dr. Bayer advised, but I like to expect it personally. Then I produced this splinted impression technique. It's very nice. You can put some music and spend a couple of minutes if your technician is not so skilled for that. Put that in a mount and take a permanent impression for permanent crowns. In the frontal region, we used the sky aesthetic abutments, and we decided to use fast and fix abutments with the lateral screws, very, very convenient abutments for this technique, because we needed to have an access to these implants for periodontal treatment on maintenance. On the other side, we used also the same abutments. And these abutments are very convenient due to some planes, and they can produce a very, very passive fit. And while you are screwing this screw, you have very good leading of the abutment in its place on the implant. So it's very, very reliable solution. What is important is you to decide where the screw is going to be. If technician is going to decide that, he could put that in very unfavorable position, so you cannot approach your screwdriver with the screwdriver to the screw. So you should determine where it's going to be. I did it by myself, so I produced some kind of also a guide for the technician. This is how it looks in a mouth. And we produced zirconia framework covered with some pink porcelain. We used the DTK bond from Bradent as well to fix the abutments inside of the mouth, inside of the construction, and this is how it looks at the end. We torqued with a wrench according to instructions, and we filled the frontal crowns with a temporary composite cement, very good one, in this case from Ivoclar. This is how it looks at the end, and it was a quite successful work for us. What I did not like is those shine through of the implants through the soft tissue. At that moment we had nothing else than this implant. I really like and welcome the fact that Bradent introduced the Nero type of implant. With Nero type of implants, I think that this problem would not be visible so much. But anyway, our patient felt very satisfied, and she just liked her smile as much as we do. I think that our future is going to bring us the new technologies. This is my son. He's cleaning teeth to his mother, to my wife. I think that this lecture, this is my email. You can contact me whenever you like. Thank you for your attention very much.